Dr. Katulis for organizing this event, and to Vicky and Athena for the invitation. I'll talk very briefly about the organization that we have here in the United States. And just as a disclosure, I'm an employee of this organization. So a little background, who are we? Well, in 2020, just before COVID hit, AMSEC, the American Society of Extracorporeal Technology, was looking to develop a nationwide incident reporting system for sentinel events in extracorporeal circulation. AMSEC was not aware, but my colleagues and I were already working on this tool. And in early 2021, we became listed with the US government, the Department of Health and Human Services, as a patient safety organization. Now, in the United States, that allows us to collect incident reports across the entire country for cardiac surgery and ECMO. The reports that are submitted to us can be submitted anonymously, and they're confidential and privileged, which means when they come in, they cannot go into a lawsuit, they cannot go into coroner's court. The information that's submitted to us can never see the inside of a courtroom. We collect reports about sentinel events, near misses, equipment malfunctions. Sometimes there's patient harm, sometimes it's just a minor event. But by law, the only purpose we can use this information for is to improve the safety and quality of care. So how do we do that? We have a website, perfusionsafety.com, and you can go here from anywhere in the world and any piece of a phone, a desktop computer, and you can see there our blue box with the orange check mark inside shows the people in the US that this is a listed patient safety organization with the US Department of Health and Human Services. So you can see here on the left, we collect reports from all over the country. Sometimes it might be a nurse who submits a report, sometimes a perfusionist, or maybe a hospital. And we take all the reports into the PSO and we put them through a standard analysis, which we talked about in the paper that we published in 2022. And we compare reports in a variety of different ways. Maybe some reports all involve oxygenators, but maybe sometimes they involve similar human factors. So they have to do with communication, or they have to do with the surgical techniques that are used. And after we complete the analysis, then we send reports back out to individual perfusionists or surgeons or anesthesia, and we can give them information about problems that are happening at other hospitals across the country, or with other specific clinical techniques or specific pieces of equipment. And on the right, you can see here, this was the paper we published in the Journal of Extracorporeal Technology in 2022. We talked about how we developed this system. So we've been collecting reports for about 3 years. And so far we have 324 reports that have been submitted to us. This is just a little bit of information. About half the reports are anonymous, and the other half of the reports, people leave their phone number or email address so we can contact them and ask questions about this report, because we usually need more information. The procedure acuity, sometimes these are routine cases, sometimes emergencies, but nothing is uniform. So over the last 3 years, we've put together a report every year that we submit to AMSEC. And if anyone is a member of the American Society, you can access these reports for free. In 2023, we did a report for them about mode confusion, where we learned that many perfusionists, many of the accidents that we were seeing at that time involved misunderstanding of the automation systems of the heart-lung machine, because there's different settings for different types of procedures or for different times within the same procedure. In 2024, we put a report out that showed 3 different mitigation strategies, which I'll go over in just a minute, that were especially effective in preventing accidents. And this year, I'll give you a small preview. We took a deep dive, a deep look at equipment failures and what can happen in there. So mode confusion is defined as when clinicians misunderstand or lose track of the operating mode of the equipment that they're using, heart-lung machine, ECMO system. And because their mental model doesn't match what's actually happening with the artificial circulation, there can be problems. When we called perfusionists or other clinicians who had submitted reports and talked to them, many of them did not know what were the alarm settings at the beginning of the case. Many people say an alarm was going off, but after, when we talk to them, they don't know which alarm was going off. Was it the low level? Was it the bubble? Was it high pressure? They have a difficult time recalling what alarm went off. They don't remember if they reset the alarm. Did they change the setting? And importantly, many people cannot say, oh, we always use that alarm, or what mode that alarm is used in. Does the alarm always cause a ramp down or servo regulation? Sometimes yes, sometimes no. So when they trigger in the middle of a case, it's difficult to know what happened. In 2024, I'm sorry, we published a report with AMSECT, and we talked about 3 different ways that are especially important in decreasing the impact of safety events. One was to have extra equipment. We called it N+1 equipment levels. Many of the reports, they would have 2 patients having surgery, 2 pieces of equipment, and no backup or no extras. The other thing was the gas supply for the oxygenator. Many reports come in where the oxygenator gas supply is only tested very minimally and not in depth. And we outlined a holistic gas supply test that will help you test all the components of the gas supply. And finally, to go along with that mode confusion, we said you should test all your alarms and interventions before the case during the pre-bypass checklist, because if the mode is changed, you may have a green light on your heart-lung machine, but the response of the machine may not match what you expect once you get into a problem situation. 20% of all the reports that we received at this time could be reduced or eliminated with these 3 approaches. This year, we were looking at equipment failures. We found that at the time we did the analysis, 15% of all reports involved equipment failure. You can see on the right, the heater coolers were the most common problems, but there were also a lot of problems with the pumps, cardioplegia systems, and the vaporizers. When we looked very closely at the reports that involved equipment problems, we found that unfortunately, many of those problems were not found out or not discovered until the initiation of bypass or once you were on bypass. And so we looked very closely and saw that in probably 30 to 35%, it was possible that they could have found the equipment failure earlier before bypass, but the checks and setups were not adequate. And in another 25% of cases, the report was anonymous and we could not ask questions, but we suspected that those cases also could have found the problem earlier instead of during the peri-initiation period or after already on bypass. Of course, you always want to find these problems earlier so that they don't impact the patient. And so we think that if we can modify our techniques, we can push these reports to the left so that those reports that are maybe coming in the peri-initiation period or after bypass actually are caught early in the morning before the patient comes in the room or during the checklist period before the patient is being cannulated. We also put out special reports. This year, we put out a report in the fall. We received 2 reports in quick succession of cannula failures for ECMO, specifically these crescent cannulas. And so we did a deep dive into, there's a database in the US called the MAUDE, M-A-U-D-E, and we found almost 30 reports of these cannulas failing in a few years, maybe 2 or 3 years. And we published that report to AMSECT, and we listed very specific ways in there that the perfusionist or surgeon or ECMO specialist could help to identify early when this is either failing or could fail. And so we have a lot of exciting work ahead of us in the future. We've actually started some light discussions with some members of the European board to see if we can use some of these techniques in Europe to help work with perfusionists and surgeons there to improve safety and quality. Of course, there's a lot of different regulations that we have to navigate, but it's an exciting opportunity. But we believe we can take this information and improve the current equipment design and also future equipment design and how a perfusionist or an ECMO specialist might use the equipment. We're looking at building clinical decision support so that when you're on bypass, if there's a problem developing, if your oxygenator is clotting, the pump could tell you before you can see it, you might have a problem with the oxygenator, maybe there's a clot, or maybe there's other problems. In the US, we can protect data, and we are looking to learn better about how we can do that in Europe. If people are collecting a large amount of data from electronic heart-lung machines or ECMO machines that have a lot of electronic data, we can protect that data in the US. And then also we design simulations for training. And when we do that, we do it like we see for aircraft, where the simulation is not designed based on somebody who reads a book and then designs the simulation. We take a case that's been reported to us and we create it exactly as it happened to another perfusionist, so that when you do the simulation, you know this is exactly how it happened to someone else. And then also we try to understand how to educate students based on what events they're likely to see. We don't want to train them to change out an oxygenator if what they really need to train is how to test their gas supply or how to test their heater cooler, because that's the major way for them to avoid accidents. So that's all I have, but I'm happy to answer any questions or engage any further discussions. Thank you so much.
Our latest Europerfusion in Valencia to have a presentation of ORUM safety in Europe, and also Richard, who is the chief. I think that he is the one that represents your company in Europe. Is that right?
That sounds correct, yes.
Yeah. And I think they're trying to find the laws and the way that this can be applied in all European countries.
I hope they're able to do so, yes.
And I would like to ask from Athena Ramu to say a few things and comment on Michael Colligan presentation.
I would like to thank you, Mike, for your presentation. It's like a science fiction for Greek reality to have a company that is dealing with accidents in extracorporeal circulation. At this point, I would like to grab the opportunity and thank all of the speakers from all around the world, from US or England, and even from Asia, that they contributed to this series of webinars that we are trying to organize. This was our goal, to try and share information from all around the world about all the current practices in extracorporeal circulation, in ECMO practices, and maybe we can learn something from all these presentations and try to implement those practices in our everyday practice. So, Mike, thanks again. I have only one question. If someone has an incident and he wants to report it to you, is there a cost that he has to pay, so you can maybe see what it's all about? Is there a cost?
So for an individual report, if someone has an event happen, they can submit it to us. There's no cost. We will send back, if they leave an email address, we will send back a summary of our analysis, and there's no cost for that. I will only say that once the report comes to us, it's protected in the US by law, but I don't know what the laws are. If you're submitting information from another country, are you allowed to submit it? Should you submit it? But nobody can come to us in the US and ask us for the information that we have.
Okay, thank you again, and keep up the good job. Thank you.
Athena,
Yes.
can I ask you a question?
Yes, of course.
What is the longest ECMO support you have experienced in your practice here or in throughout the world? What is the longest ECMO support?
Personally, I believe it was the longest ECMO support.
ECMO support, yes.
ECMO support. So,
Is it more than a month?
40 days.
Yes, 40
40
days.
days.
We had 40
Yeah.
days. Yes.
Yeah. Okay, great.
Mhm.
And have you experienced accidents as well in all these?
I believe small incidents. Yes,
Yeah.
I believe that everybody has had dealt. But accidents, thank God, no.
Like
Yes, major catastrophic accidents, no, we didn't have any.
Okay.
Yes,
All right, thank you very much.
thank you.
Next, we would more